Hello everyone. In this video I wanted to talk about thyroid nodules. It's one of the things that I deal with a lot in my practice, and I thought I would make a video for my patients and for anyone else who's interested. Going in a little more detail about the thyroid nodules, which a lot of times I don't have time to go into in the level of detail I would like during a clinic visit. Okay, so the first thing to know about thyroid nodules is that, especially in the United States, most thyroid nodules are found incidentally, which means that people don't know that they have them. They're not palpable, you can't feel them, but they were getting like a thyroid ultrasound or a CT scan for some unrelated reason. Maybe they had some neck pain, or they were in a car accident, or for some reason they got a scan or an ultrasound, and then people discover that they have a thyroid nodule, which they were not aware of. Thyroid nodules do not cause any problems generally. They don't change your endocrine function. Your thyroid will function normally even if you have a thyroid. I liken it to having a mole on your skin. Having a mole on your skin isn't, quote, normal, but it doesn't affect the function of your skin. It works fine. And so thyroid nodules generally do not affect the function of your thyroid. Your thyroid will make the thyroid hormone and function normally. And they are quite common. They increase as you get older, and generally more than half the people will have them by the time you're age 60. The studies, depending on which studies you look at, they say there's a prevalence of 19 to 67% in the population. But the rule of thumb that I generally tell people is whatever your age is, that's probably the chance, that's like the percentage chance that you have a thyroid nodule, roughly. If you're 20 years old, you probably have a 20% chance. If you're, 50 years old, you probably have a 50% chance. If you're 60 years old, you probably have a 60% chance. So extremely common. Lots of people have thyroid nodules. Most of them are asymptomatic. They don't cause any problems, like we said. But once you get a thyroid nodule, then the question is really what we want to know is does this thing represent a thyroid cancer? And I'll kind of go over the workup of these nodules and why I believe they're not as serious as many patients think. All right, so first thing is recently a lot of radiologists and people have realized that just because you have a thyroid nodule doesn't mean it needs to be worked up. A lot of thyroid nodules are very low risk for cancer, and they don't necessarily need to be worked up, or nothing further needs to be done. So many places have developed systems, and they're called TRAD systems, which stands for Thyroid Imaging Reporting and Data System. So many different organizations have different criteria they use to generate a score. And there's like the British Thyroid Association, American Thyroid Association, American College of Radiology. In the US, most of these will use the ATA, American Thyroid Association, or the ACR, American College of Radiology, TI-RADS score. So they will generate a score, and based on the score, it will be classified as a very low risk to a very high risk nodule. So low risk nodules do not need to be biopsied. They don't need to be observed anymore. And then the higher the risk is, the smaller the nodule can be before they recommend a biopsy. So the radiology report will generally say, oh, observe it every 2 years, or it's benign, don't worry about it, or it should be biopsied. And then a biopsy is done with what's called an ultrasound guided fine needle aspiration. So they use an ultrasound in your neck, and they use a very thin needle, and we take a few cells out of there, and the cells are looked at under a microscope by a pathologist to determine whether it's likely to be cancer. Now, the confusing thing about this is what happens is when you get this biopsy, what happens is it doesn't give you an answer of it's cancer or it's not cancer, which is what most people would expect from a biopsy. That's because when they take the cells out, sometimes there's not enough information from the cells for the pathologist to say one way or the other that it's a cancer or not a cancer. So what they have is something called the Bethesda classification, and they classify it from 1 to 6. So let's go over this. 1 says it's non-diagnostic or unsatisfactory. That means you didn't give them any cells. The biopsy specimen just had blood in it or just had fluid in it. There's just not enough cells for them to even look at to give you any kind of answer. So 1 is basically a non-diagnostic. What can happen is if you have a cyst, if your thyroid nodule is essentially just a cyst, it's full of cysts, you're going to get a number 1 because it's not cancer, there's no cells in there, and you're just going to get cyst fluid. And it's impossible to give them enough cells from a cyst for them to make a diagnosis generally. Then 2 is benign. That means that they've gotten enough cells and they look at the cells and the cells look very benign. So they're very sure that it's benign. Then there's 3. 3 means atypia of undetermined significance or follicular lesion of undetermined significance. That means the cells look a little weird, but not super weird. And then 4 is follicular neoplasm or suspicious for follicular neoplasm. That means the cells definitely are not normal. There's some kind of neoplasm. Neoplasm means some kind of tumor. Doesn't have to be cancer. It could be a benign tumor. But it is some kind of tumor, but they don't know if it's benign or if it's malignant. Malignant meaning cancer. 5 means suspicious for malignancy. That means it looks very much like cancer, but they're not sure enough to actually call it cancer. And then 6 means it is cancer. They've decided, they've looked at the cells, and they've decided, yes, it is cancer. So what does this mean? If you get a Bethesda class 1, your chance of it being malignancy is between 5 and 10%. That means they recommend repeat. Now, if it is a cyst, generally we wouldn't even bother biopsying these. No matter how many times you repeat it, you're not going to get a diagnostic biopsy. Then 2, benign. That means your chance of being cancer is between 0 and 3%. This NIFTP is a thing they used to call cancer, but we decided it's not cancer anymore. It stands for non-invasive follicular, oh shoot, I forget now. But it used to be considered a cancer, but it isn't anymore. It'll come to me when I think about it. Okay, so this Bethesda class 3 means there's a 6 to 18% chance it's cancer. And then Bethesda class 4 means there's a 10 to 40% chance it's cancer. Bethesda 5 means it's a 45 to 60% chance it's cancer. And if it is, they call it malignant, it is a 94 to 96% chance that it's cancer. So you can see as the Bethesda classification goes up, it's more and more likely to be cancer. And the question is like, usually if it's 5 or 6, people are like, yeah, we better do surgery and take the thing out. And then if it's benign, people are like, of course, we're not going to take the thing out. Now, the question is, what do you do with 3 and 4? With 3 and 4, you're between 6 and 40% chance of cancer. That's a pretty big range. And some people are like, they don't know what to do with that. And so there is this thing called molecular testing nowadays. And the 2 major molecular tests are from a company called Afirma. So Afirma here, and then another company that runs a test called Thyroid. So these things, what they do is they take the cells from the biopsy and they run it through these genetic tests, and they look at many different genes, and they tell you whether it's more or less likely to be cancer. It's not 100%, but it can move the needle one way or the other. It can say, it's like a 70% chance you have cancer, or a 5% chance you have cancer. So it can move the needle a lot more. So if that's helpful, then we can run molecular tests on you. For some people, they just want a one way or the other answer, and you just can't get it. There's just no way. Now, thyroid cancer is not very dangerous in most people. And when I say that, I'm talking about the most common kinds of thyroid cancer. There's many different kinds of thyroid cancer. There's papillary thyroid cancer, there's follicular thyroid cancer, there's medullary thyroid cancer, and anaplastic thyroid cancer. Now, in this video, we're basically talking about follicular and papillary thyroid cancer. Those are the 2 well-differentiated thyroid cancers. They represent more than 90% of thyroid cancers. And they're the most common ones. So those 2 are not very dangerous. And let's look at this paper from 2010 looking at what we call the SEER database. The National Cancer Institute has this thing called the SEER database. They look at all the cancers in the United States, or a large percentage of them. And what they did is they looked at all the patients with papillary thyroid cancer, which is the most common kind, that was limited to the thyroid gland. So these are thyroid nodules. They have not spread beyond the thyroid gland, but they're known to be thyroid cancer. In their database, they found 35,000 of them. And then 1.2% of them, so 440 of them, did not go, they did not undergo treatment. All right, so they followed their 20-year cancer-specific survival. So amongst the people that, let's see, okay, amongst the people that were treated, their survival was 99%. So it's very good. If you get treated for thyroid, like if you were to pick a cancer to get, you would want to get thyroid cancer because it's the most treatable cancer. So their survival for basically thyroid cancer that's confined to the gland, it was 99%. Now, if you did not get treatment, your survival was still 97%. And that's pretty amazing. So the corresponding estimate for the people who did receive treatment was 99%, but the people who did not receive treatment was 97%. Now, it doesn't mean they never received treatment, but they did not undergo immediate treatment, so they waited a long time. And their survival did not diminish much. There's another study out of Japan that they followed several, I think it was about 100 patients that didn't undergo surgery, and the vast majority of them, over a 5-year period, their cancer did not progress. So these are people with known cancer, and their cancer did not progress. The other thing that we want to know is if you're young, under age 45, then thyroid cancer has almost no impact on your life expectancy. Most people who are under age 45 have no impact on. So here you go. There was no reduction in life expectancy for those younger than age 45. So it's even people that have very advanced disease, if you're under age 45, you do quite well. And here's the last paper I want to kind of talk about today. Interestingly, in South Korea, the government instituted a plan back in about 2012 of screening their population for thyroid nodules and undergoing kind of aggressive treatment. And what happened is that once they started screening their population, they found a lot of thyroid cancers that would have been unknown. So their incidence of thyroid cancer increased significantly. So here's what you see. Regionals, you see this line right here is the incidence. So you can see there's more and more people being diagnosed with cancer because they're just screening more people. But then you see mortality. Mortality doesn't change. So even though they were finding more cancers and they were doing more surgery, they were not preventing any deaths because the deaths were so little to begin with. And so they did not save anyone's lives by screening all these people for thyroid cancer and treating them. I believe the number of thyroid surgeries that they did increased by over 1,000%. And yet you would think that if you're treating 1,000% more cancers, that you would decrease the deaths from those cancers by 1,000%. But that's not what happened. They did 1,000% more surgeries, but their deaths remained exactly the same. So it shows that there's gross overtreatment of most of these cancers. Now, that doesn't mean that it's 100%. You know, when you say 99% survival, it means 1% of people die from this. So what we don't know right now is which people do poorly from these thyroid cancers. We just don't know. We don't know what factors make it because some of them do behave very badly. The rare ones are very aggressive, they invade things, and people can die from them. But we just don't know which one it is. What we do know is that for the vast majority of people, even untreated thyroid cancer doesn't kill them. For young people, even advanced cancer usually does not decrease their lifespan. And most of these are very slow growing and don't cause any problems. So, how to deal with these indeterminate nodules is kind of up to every person. Some people are like, even a 10% chance of cancer, I want to know and I want to have surgery and I want to take it out. Other people are like, hey, it's a 50% chance of this cancer that even if you don't treat it, most people are fine from it. I don't really want to undergo the risk of surgery. I'm okay just kind of keeping an eye on it and watching it. And I think both of those are reasonable ways of thinking about it. And that's why this is one of those things that if you go to 4 different surgeons or 4 different endocrinologists and ask them their opinion, you're probably going to get 4 different answers because there isn't a clear-cut right or wrong answer. It's a very slow-growing, very easy to treat cancer in most cases. And there's uncertainty about the risk of the cancer in this group. And so some people are very aggressive and they say, thyroid surgery is very safe, the complication rate is very low, and it's better to know. And other people are like, well, even a very safe surgery is not a 0% risk of complications, and most of these things are not going to be cancer, and even if they are cancer, the cancer is very slow growing and does not kill anyone really. It has a 99% or 97% success rate in treatment, even with or without immediate treatment. And so it's okay to watch them. So that's a kind of a personal decision based on people's relative fears of and concerns about surgery versus their relative fears and concerns about a relatively indolent and not dangerous cancer. So that's something that you can think about. I will link these papers in the description below if you want to read them yourself to get more information. If you have any questions, please comment below and I'll try to answer them when I get the chance. Of course, my answers in this video, I am not your doctor. It is not medical advice. It's just information that I'm happy to give you. But it's not medical advice. If you need medical advice, you need to go talk to your own doctor. All right. Thanks for watching.